Good afternoon and welcome. I'm John Iskander. Welcome to the September 2014 CDC Public Health Grand Rounds. On this 5th anniversary of the first Grand Rounds, special thanks to the founding director of Public Health Grand Rounds, Dr. Tanya Popovich, and to CDC leadership for their continued support of and active participation in Grand Rounds. I'd also like to extend a special thanks to colleagues who allow us to broadcast Grand Rounds from CDC, including from our new location today, and those in the studio who work with us to support tapings. We'll continue to strive to make CDC Public Health Grand Rounds an important part of the shared scientific culture of public health. Grand Rounds is also available on all of your favorite social media sites. We have a featured video segment on YouTube called Beyond the Data, which we post shortly after the session. Continuing education credits for Public Health Grand Rounds are available for physicians, nurses, pharmacists, health educators, and others. All of this information is available on the Grand Rounds website. We've partnered with the Stephen B. Thacker CDC Library to feature scientific articles relevant to this session. The full listing is available at the CDC Library website. In addition to today's outstanding featured speakers, whom I'd like to thank for their important and ongoing work, I'd also like to acknowledge the important contributions of the individuals listed here. In the spirit of Amazon, if you like this session, here are some other Grand Round sessions worth checking out with related topics. So now, with additional thanks to those helping us out in our special location for today, it's my pleasure to introduce Admiral Robin Akita with some introductory remarks.
Thank you, and good afternoon. Good afternoon. Welcome to Grand Rounds, and especially want to welcome you to the Chambly campus. This campus is home to 3 of the 4 non-communicable disease centers here at CDC. In addition to welcoming all of our panelists, I also wanted to give a special shout out to Georgia State University School of Nursing. I heard there are several of you in the audience. So thanks for joining us today. Each year, more than 1.5 million Americans will have a heart attack or a stroke. These events contribute to almost 800,000 deaths each year in cardiovascular disease. That's 1 in 3 deaths each year in this country. The trauma to families and communities is devastating. The cost to the U.S. economy is nearly $1 billion each day in medical costs and lost productivity. Million Hearts seeks to prevent 1 million heart attacks and strokes over a 5-year period, sharing our goals and our irrational optimism about the preventability of heart attacks and strokes with others. Million Hearts is co-led by CDC and CMS, bringing together public health and clinical medicine in unprecedented ways. Million Hearts is about defining the most impactful strategies in clinics and communities, embedding measures that monitor and reward improved performance in those measures into reimbursement programs, and learning from grassroots leaders what is working to control important risk factors for heart disease like hypertension, tobacco use, and excess salt in our food supply. The most exciting and promising collaborations in Million Hearts bring together the complementary assets of the public health and healthcare sectors. Many powerful examples exist, and today's presentations will highlight just a few models of the work that partners from both the public and private sectors are doing to achieve the goals of Million Hearts. Specifically, we'll hear about how public health and clinical care experts are coming together in health systems and in communities to improve blood pressure control, how comprehensive tobacco policy efforts can be scaled to have a statewide impact, and how efforts to promote healthy nutrition can occur by increasing the availability of lower sodium products through policy change. We'll also hear about the data showing the progress that has been made through Million Hearts, along with the work that is still needed to achieve our goal of preventing 1 million heart attacks and strokes by 2017. And while we applaud the success to date, there's much more that we need to do. We're halfway through the initiative, but we've not yet prevented 500,000 events. So now is the time to go all in, for us to really push all those chips to the center of the table. We're more convinced than ever that Million Hearts is the right thing to do and that we are focusing on the right approaches. But we know that this is hard work. And so as we pass this midpoint milestone, we look forward to really encourage our partners across the country to commit and then recommit. The ability to address the nation's public health challenges, and the biggest one being heart attacks and strokes, depends on public-private partnerships and goal alignment. We know that strategic collaborations are key not only to the success of Million Hearts, but really are the future of public health. Partnerships allow us to speak with one voice that is both expert and passionate and amplify the call for improved heart health in this country. So together we can send a clear signal that life-threatening and life-ending cardiovascular events can be prevented if each of us takes a few specific impactful actions. Thank you.
Thank you very much, Admiral Ikeda. Our first speaker will be Dr. Janet Wright.
Good afternoon, everyone. I'm Janet Wright, Executive Director of Million Hearts, and on behalf of the entire Million Hearts team, both here and at CMS and other places, I welcome you to CDC's Grand Rounds. Despite the decline in mortality rate over the last 40 years, cardiovascular disease does remain the #1 killer for men and women and for all races and ethnicities. As Admiral Ikeda said, more than 1.5 million people suffer a heart attack or stroke each year, and these are devastating events. They cause 1 in 3 deaths, and they rob families and communities of loved ones, and it's time that it stopped. It's time that we stopped losing $1 billion a day in lost productivity and medical costs as well. And in 2010, life expectancy for the Black population was 3.8 years shorter than that of the white population, with cardiovascular disease mortality accounting for more than a year of that difference. This map shows that the variance variance in preventable deaths by county. As you see, the highest preventable death rates occur primarily in the South Central Census region. The good news is that with good habits and good care, heart disease can go away from this country, that we can have a heart-healthy nation. Million Hearts is designed to actually realize that vision. As Admiral Ikeda said, it is a national initiative launched in January of 2012 by the U.S. Department of Health and Human Services. It's co-led by CDC and CMS, and the concept was to bring together complementary strengths of public health and healthcare. The co-leads are associated in deep and meaningful partnership with federal and state agencies and the private sector. We know that it will take specific, focused action by all to achieve this goal, and you're going to hear about progress today, as well as what you can do to accelerate that progress. To prevent 1 million heart attacks and strokes, we need to do 2 things. We need to change the environment in which we live and work and play, and we need to achieve excellence in healthcare. Both are daunting, but absolutely possible through the right partnerships and the right actions. Communities can help their citizens stay healthy by increasing access to smoke-free spaces, lower sodium choices, and by eliminating trans fat in the food supply. Healthcare professionals and the people that they serve can avoid and prevent heart attacks and strokes by prioritizing what we call the ABCS. So that's aspirin when appropriate, blood pressure control, cholesterol management, and smoking cessation. And by deploying health information technology and new models of care, as well as quickly scaling and spreading those models that prove effective. And finally, by focusing on the populations with the greatest burden of disease and the greatest risk, we can guarantee for our nation continuing returns on this 5-year investment for many years beyond 2017. So that's the framework. Let's take a look at the targets. For the environment, what we need to do is we need to reduce the use of combustible tobacco products, reduce daily sodium intake by 20%, and eliminate the consumption of artificial trans fat. On the clinical side, we are aiming for a 70% performance across all of the ABCS, an ambitious but achievable target and a healthy down payment on the million prevented events. Achieving 70% for those patients that are in clinical care settings will help pull the population-wide target up to 65%, because that includes individuals who are not in usual care, not connected to a usual healthcare setting. So let's talk about a few of the challenges and some solutions that are already being brought to the table in Million Hearts. We'll start with the challenges. First of all, many people believe that the family history dictates the family future, their fate. Not every person or agency or organization can put cardiovascular health at the top of its priority list. We know what works for cardiovascular prevention, but we do not always implement systematically. And then finally, we often work alone. Over on the solution side, we know that clear actions and examples of those who have achieved results, like the speakers you're going to hear from today, will show that the family future is actually yours to write. Until cardiovascular disease is no longer the leading cause of death in this country, it's a priority for all Americans. Specifics about the how and rewards for results will help us accelerate progress. And finally, big jobs like preventing 1 million events requires a team, and in fact, many teams. So we want to show you a few examples of how this is working in Million Hearts. First of all, the mission of Million Hearts has meaning, literally for millions of people touched by this disease. We've seen a deep and genuine teamwork across the Department of Health and Human Services and well beyond, producing results and also very valuable resources. High performers, again, like you'll see today, are honing and spreading the strategies that work. And programs in the field are breaking down traditional silos and amplifying their reach and impact. In 50 states, federal programs are working together to drive success. Among these are many HHS regional leaders, ONC's regional extension centers, state departments of health, quality improvement organizations, and we have representatives here from the new QIO/QIN in Georgia and North Carolina, state innovation models and conference of care practices, as well as state Medicaid agencies. And in the private sector, we've seen state chapters of medical and nursing and pharmacist organizations, numerous community-based and faith-based organizations, medical groups, large and small, and businesses and business alliances. But the most exciting thing is the dynamic and organic collaboration between and among these stakeholders. Some of these new collaborators are listening in today, and all are contributing time and talent to preventing heart attack and stroke. This table shows a subset of the indicators that we are tracking: adoption of electronic health records, reporting on quality measures, and widespread adoption of sodium procurement and smoke-free space policies can help set the foundation for the results and the success that we're after. Our intermediate outcomes are improved performance on the ABCS and sodium. We're monitoring results from the robust surveillance surveys that you see here, available every 2 years. And also we're monitoring clinical quality measure reporting systems that can provide annual snapshots of participants, a subset of the national participant list. And here you see our long-term outcomes. CMS provides quarterly claims data to monitor our long-term outcomes, the numbers of heart attacks and strokes among Medicare fee-for-service beneficiaries. Current data show that 8 heart attacks and 8.5 strokes per 1,000 beneficiaries, or over 50,000 heart attacks and 55,000 strokes occur each quarter. As performance on the ABCS improves, we will be looking at these data for an impact on that ultimate long-term outcome. With the monitoring plan in mind, let's take a look at some exciting examples of progress to date. Since Million Hearts launched, 127 additional communities have gone smoke-free, a decision that leads to an almost immediate drop in heart attack rate within that community. Tips from Former Smokers has brought 150,000 people to quit lines. Pharmacies can be sources of expert advice and support. CVS Health's new policy is one to be celebrated and emulated. And hospitals, school systems, and other food purchasers are using the power of procurement to increase access and availability to lower sodium foods. You'll hear about one of these efforts today operating in Los Angeles. One requirement for rapid performance improvement is timely data shared with teams, with patients, and others. While we await the biennial results from NHANES, reported every 2 years from NHANES, we are actively monitoring other data sets on the Million Hearts Clinical Quality Measurement Dashboard. Available now on the website, this dashboard shows how your state, region, and the nation are performing on the ABCS. This snapshot is from HRSA's uniform data set. We also will have data sets from HEDIS and from CMS's physician quality reporting system. This snapshot shows HRSA's federally qualified health centers making substantial progress in smoking assessment and treatment, as reflected by the change from red to yellow and even to green. We're excited to share these state-level data sets and look forward to working with partners to help them show their progress. At the heart of Million Hearts is progress in reducing disparate outcomes in cardiovascular disease. We are encouraged by the work underway in the populations hardest hit. Only a few examples are noted here, each with reach and impact and potential for spread. In addition to the CDC ASTO project in 9 states and DC, and the QIO work noted here, we're delighted to work with partners such as the NAACP and over 70 faith-based organizations who are committed to improving cardiovascular health. To prevent 1 million, 6.3 smokers must quit. 10 million more people with hypertension need to bring it under control. And all of us need to reduce our sodium intake by 20%. We seek these outcomes for all Americans, but will focus in populations with the greatest burden and at the greatest risk. Today, you'll hear experts describing their field-tested examples of success in implementing what works to prevent heart attack and stroke through hypertension control, smoking cessation, and sodium reduction. As you listen, decide how you will disseminate and deploy the lessons learned, how you will scale and spread their innovations, and unleash this powerful collaboration of public health and healthcare in your community. I look forward to hearing your questions for the panel, and as always, we look forward to your advice to all of us in Million Hearts. Our first speaker today is Andrew Tremblay.
First of all, thank you for having me here today. My name is Andy Tremblay. I'm the chair of the Department of Primary Care at the Cheshire Medical Center, Dartmouth, Hitchcock, and Keene. And I have to apologize. I am a sorry stand-in for the president, but I figure, hey, we'll start there. So what I'm going to do is take you on a whirlwind tour here through an 18-month project that we started on in our institution. And when I say whirlwind, I do mean that. So bear with me as we move. So I'm going to set the stage here. For many of you, you've heard about the 3-part AIM or the triple AIM before, and this is our take on it. We wish to create a culture of health, not only in our institution, but outside of that. Most of the residents in our area do seek their health care with us, as the nearest healthcare facilities outside of our institution are between 30 and 35 miles away, but not everybody seeks their care with us. However, we feel a responsibility to our community to make sure that we are a resource for them in whatever capacity that may be. And so our goal is to improve the health of all of the residents in our community, not just those that seek the immediate health care with us. Overall, of course, because they do utilize our ER and our hospital services, the end goal is to decrease costs and allow investment in prevention in primary care. As a result of that, we came up with a rather elaborate model, which I kind of like, and this is an integration of the public health system and the medical care system, and I'll sort of walk you through that very quickly. You can see on the far right here, it talks about complex medical care. Those are things that primarily live in the medical environment, your hospital and your clinics. As we move into this sort of overlap area, we talk about patient-centered primary care, medical homes, facilities that are interested in providing wellness care and dealing with chronic disease management. On the extreme left, you see those things that are really out there in the community that equally impact patients' health, but aren't necessarily things that are happening within the confines of your facility. And then in the intersection here is how do we work on, as was said earlier, the protection of our vulnerable people, those people who bear the highest risk and burden of risk. This is what we call integration, and this is what we're striving for in our rather small community. This is what we hope will transform healthcare going forward, and we've had fair success with this in a number of programs that we've instituted thus far by creating collaborative efforts with our community partners, both organizationally and as individuals. Some background on CMC-DHK. We have about 38,000 adult active patients. We have over 125 providers. We are a multi-specialty clinic. We have 32% of our patients have hypertension. That's in the age range of 18 to 85 years. So that's about 12,580 some odd patients. I know those numbers because I sleep with them and live them every day. About 8.5% are Medicaid eligible, 3.7% represent a racial or ethnic minority. We are a very, very heavy Medicare dependent environment, as is most of northeastern United States. As we began to look at this, the thing that really set us up for hypertension was understanding what's happening in our community. Unlike other places in New Hampshire, we tend to deal mostly as high causes of mortality and morbidity with coronary artery disease and stroke for obvious reasons, as were previously mentioned. As we worked on this, we decided that hypertension should be our first task to sort of look forward to, and we began to look at some of the inconsistencies as to why we're not doing better with our blood pressure control or as well as we would like to do. We found a number of inconsistencies, including workflow between primary care teams, their medical homes and providers, the engagement of specialty care departments. That's an issue when you work in a multi-specialty clinic. The documentation, especially of second blood pressure readings, inconsistent blood pressure technique, which honestly at the outset of this project was a significant sort of hidden thing that we found, but was incredibly important, and lack of timely maintenance and calibration of equipment also. Other barriers that we observed were the following: the cost barrier of blood pressure rechecks. Patients have high deductible insurances. They can't afford always to come back in a timely manner. Lack of resources to effectively manage registries, which are an important concept and tool in health population. No agreement on a universal triage or treatment algorithm within our group. Varied process for flow staff, in other words, those providers of care who put patients in rooms to notify us of elevated blood pressure. Lack of engagement of and alignment of patients in the community. So patients, once they left our office, what was their incentive to continue the plan and protocol? When we started this, we said, what should our goal be? I think it's important to know that we did not start where the national average is, which is generally somewhere, depending on the studies you read, between 35 and 45% hypertensive control. We actually started really well. We were at 74%. So we set a goal of 81%, and the reason we chose that number is we used an internal benchmark within the Dartmouth system. That is that a provider had been able to achieve, with a substantial number of patients, 81% hypertensive control. We felt if this individual could do it, we could do it as a group. So the strategies we then deployed were using a multidisciplinary quality improvement team, which we enlisted the role of what we call hypertension champions. So imagine an orthopedist sitting on this group. It's kind of interesting. We created free nurse clinics so that blood pressure rechecks were no longer an issue in terms of cost. We actually wrote policy into how we provide care to eliminate that cost barrier. We implemented protocol-based modifications so that the nurses knew what to do with an elevated blood pressure, specialty knew what to do with an elevated blood pressure, and new to us and new to this concept was what our community partners like the YMCA, the nursing homes, visiting nurses, so that they knew what to do. We used our electronic health record, or EMR, to provide provider-specific registry coordination so that you as the provider had a predominant hand in how you managed your population. And we began rolling out behavioral health strategies used to engage patients in other places that were not within the confines of our institution: work, home, nursing homes, other aspects of the community, even like fire departments and our local YMCA. So we had 10 strategies for success after we went through this process, and they're very well outlined here. I'll share them with you. So we convened a multidisciplinary team, and I do mean when I say multidisciplinary, we did have orthopedics at the table. We did have ENT. We had nursing. We had medical secretary. We had community partners. We had exercise fitness gurus coming in from outside to work with us. We did win through a quality improvement process that we have, our Chairman's Award, which is fairly prestigious for us in 2014. We surveyed primary care providers and our nursing staff and patients, actually, which doesn't say there, about their barriers to adequate blood pressure control, and used all of that information to help forward our process. The one that was a shock to all of us was calibrating cuffs, and I'll pause a moment on this. When we got to it, 75% of the blood pressure cuffs on our campus were not calibrated correctly or were broken. We also realized we had 7 different types of blood pressure cuffs, and so through this process, we addressed that issue and eliminated that barrier to adequate blood pressure management. We then took that to our communities and helped assist them with the purchasing of their equipment and how to standardize their calibration. We created a core competency for all nursing staff, certainly within our organization, but spread that to our communities as well. We went to our nursing homes, our visiting nurses, our YMCA, fire departments, any place where we knew our patients would go to get a blood pressure, with the exception of automated kiosks, and made them take our core competency exam, both hands-on and net learning. We distributed a single blood pressure brochure throughout the community. So every organization in our community uses our blood pressure brochure that we developed as part of this community. There are no others. So the information is current, it's standardized, it's reviewed every 6 months. We created a nurse clinic, which allowed for no-cost blood pressure and centralization of resources. Created a single evidence support triage and treatment algorithm. So not only does this provide process to get patients where they need to be, it allowed a new tool for us to utilize in directing care for these patients, whether it was simply education, smoking cessation, dietary recommendations, or medication management. We provided individual provider registries, which we'll show you in a moment, that gave monthly data feedback, which we still do on a regular basis with a number of quality metrics for providers to see. And this is a live in-person deal that we do in our office. We will substitute a patient visit to allow this work to occur because we think it's that important. So we have added registry managers to help us with this, and they become integral parts of our team. We have incentivized providers. It is true we do use a quality incentive in our compensation. 5% of compensation is based on how you're doing with your hypertension control. We have 4 other quality metrics we use as well. And we widely distributed something that we call Know Your Numbers. Actually, Dr. Fedrizzi was down here, I believe, last year and demonstrated the Know Your Numbers wallet cards. We've issued over 12,000. We have 12,580 hypertensive patients, so we've got about 580 people yet to touch. So I think we're doing pretty well. This is an example of how our EMR downloads information to an Excel spreadsheet form. This happens to be my registry from a couple of years ago. And you can see the name of the provider. The patient identifier has, of course, been removed. You can see their blood pressure, when it was taken, and then their specific PCP comments, those things that I've shared with my registry coordinator about how I would like this patient attended to. This is a different type of data that our providers are able to see every visit. And what I like about this slide as we were putting this forth for our board to see is that the blue graph represents all the patients that we have with elevated blood pressure. The red is those patients that are Medicare because we are part of a Pioneer ACO. But we also wanted to make sure that our process was not really just limited to those patients in a certain payer mix. So you can see that the green is all patients that are non-Medicare, and the process worked for everybody regardless of payer mix because we just set it up that way. We did not design it to be specific for that. As we got into this, we realized that our mission really integrated quite nicely with the Million Hearts program, and as a result of that, we decided to apply for Million Hearts Champion status. And this is an example of how this graph that I showed you earlier, this pictogram, actually worked in regards to blood pressure. You can see how the medical care system is way involved at this end, sort of as 25% of that graph, if you will. But the other 3/4 of this represent things that could occur either outside the community or in an integrated fashion. So we were very excited to receive our championship status, and they came and visited us earlier this year. So here's the actual success story. You can see where we started, around 74%, 73.8%. And by the end of just a very short period of time with a very steep incline in this graph, we've achieved 85%. I'm happy to say that the data that came out in September, and there is a 2-month lag in that data for us that we get, does have several providers in our department that are in excess of 90% control of over 500 patients apiece, including myself. I have 850 hypertensive patients. I'm at 96% control. I'm not sure I'm going to do much better than that. Maybe. We'll see. I keep pushing. As a result, you heard about ASTO. We were awarded one of the grants to do this, and this allowed us to actually take what we had done and see, does this work in another environment? So we worked with some of the federally qualified health centers in Nashua and Manchester, distributing these tools that we created, registries, the concept of a second blood pressure check, et cetera, to help them. And what we have seen in those two particular health centers is 6% and 8% improvement in their blood pressure control, respectively, over a 6-month period of time. It's pretty impressive for such a short order and a relatively chaotic environment that generally does not have continuity, as there's a lot of transient care that occurs. So we're really trying to move these strategies into a more diffuse area. We have strengthened our relationships with our Manchester Department of Health as part of this process. As mentioned earlier, we have done a lot of work with the YMCA. I'll mention one in a moment. And we have also been working with a lot of the other community health centers in our state to disseminate this information. There's still plenty to do, though. We're expanding our registry coordination to include comprehensive chronic disease management, diabetes, COPD, coronary artery disease, CHF as a whole. Explore the use of blood pressure kiosks in our own facility and how they can feed into the EMR, which would be helpful for us and, again, save time for patients. Activity is a Good Medicine is a wonderful program we started where our organization, independent of outside financing, has subsidized memberships for our patients to join the YMCA. Costs $25 for 3 months. That's a pretty good deal. And we collect their biometrics back so we can see how the program is working for them. They get free dietetic care from Keene State College. It's a wonderful program. Integrate nutrition counseling and therapy, which is an ongoing effort for us in all of our chronic disease. We are looking at pharmacy integration. I heard that might be next Grand Rounds topic. It's very important to us. It's a great resource that we feel in healthcare has not been tapped adequately, at least in a traditional clinical environment. Spreading our improvement, which we're already working on, and a plan for maintaining our gains to make sure that we do not slip back. So it has become a part of our culture now, and we want it to stay that way. Our next speaker this morning is Patricia Henley.
Good afternoon. I'm here to present to you the work of the Massachusetts Tobacco Cessation and Prevention Program and how local comprehensive tobacco control policy efforts can be scaled to have a statewide impact. Massachusetts is 44th in the nation for land area, but it's 13th in the nation for population at about 6.3 million, and we're first in the nation for the number of local public health departments. The Massachusetts Constitution grants broad authority to cities and towns to make their own laws and regulations, and there are 351 municipalities with a limited form of a limited county government. Each municipality has a board of health that can pass local regulations, and so because of this, Massachusetts has been able to develop many tobacco control regulations at the local level. The current adult smoking population in Massachusetts is 16.6%, but there's still a long way to go to bring smoking rates down for all Massachusetts residents. 77% of Massachusetts smokers fall in one of the categories under more likely to smoke, such as LGBT or low SES or in poor mental health. In 1993, a referendum was approved for a 25-cent cigarette tax dedicated to the Health Protection Fund, and that funded the Massachusetts Tobacco Control Program, or MTCP. In 1994, MTCP had a $52 million budget. We funded 95% of those 351 municipalities. So we funded an award-winning, hard-hitting media campaign, established the Massachusetts Smokers Helpline, funded local tobacco treatment in many community health centers and hospitals, and also provided funding to local school departments, police, and fire departments. And all that changed dramatically, though, in 2003, when we had a state fiscal crisis and a new administration. The consequences of a limited budget, which decreased to $2.5 million, was that it forced us to change our strategies to a more population-based approach, and it also forced us to focus on priority policies. But there were some very wise people at MTCP at the time, and they worked very hard to maintain a core infrastructure, and that included local programs, our boards of health programs, community partnerships, and youth, a very strong surveillance and evaluation team, legal and policy technical assistance team. It kept our quit line, and that included our QuitWorks program, and communications that included stakeholder education, earned media, which was critical because that's the media that you can't buy, and then also some paid media. And all of these contribute to promoting sustainable policy change. So the local programs are really essential to the core infrastructure. Our local boards of health programs are the center of regulation and policy setting for the municipalities. They educate their decision makers, and then they enforce all municipal tobacco regulations. The community partnership programs provide community education, connect people to resources, and they get the messages out. They are the primary contact with local media outlets, and they generate earned media, and they build local partnerships. And the 84 Youth Prevention Program, which is named after the 84% of youth who choose not to smoke in Massachusetts, it's a local chapter structure, and it's focused on youth engagement. Young people work to educate their peers and their decision makers about the need for strong anti-tobacco policies, and then also about the impact tobacco has on their lives and the lives of their peers. So all three programs, local boards of health, regional community partnership programs, and the 84 youth programs, work together to amplify the key messages to bring tobacco issues to the forefront in their communities. MTCP provides the guidance and the direction for all strategies for the local programs of the core infrastructure. Technical assistance is provided in the form of model regulation language and statewide support for communications, youth engagement, and policy, and it provides assistance to passing local regulations. MTCP has developed standardized communications messages and tools that promote policy initiatives, and we encourage collaboration and unified messaging among the field. So regional community partnership programs and youth programs provide public support for policy initiatives. Then the local boards of health programs enforce the policy after it's passed. Integration of the field and the field messages is key. MTCPs is focused on these 5 priority areas, and they're supported by our infrastructure. So providing access to comprehensive cessation benefits will increase the percentage of smokers who make a quit attempt. Protecting youth from tobacco industry tactics reduces the initiation of tobacco use by youth. Increasing the price of tobacco will reduce tobacco use overall, and ensuring all smokers receive intervention by their healthcare provider will motivate smokers to quit. Protecting everyone from secondhand smoke will help eliminate the health problems caused by secondhand smoke and support the social norm that most people don't smoke. So priority 1, access to comprehensive cessation benefits. In 2006, the Massachusetts Medicaid program established a benefit that provided comprehensive smoking cessation coverage to all Medicaid enrollees. Our infrastructure supports the promotion of this benefit to increase its utilization. The Quit Line discusses health benefits with its callers. The QuitWorks program educates healthcare providers about the benefits so that it increases patient interventions. And the local community programs promote the benefit cessation resources. 44% of the callers to our Quit Line have Medicaid insurance, so we're reaching this population. Priority 2, protecting young people from tobacco industry tactics. Local retail regulations are primary to our efforts to reduce the initiation of tobacco use among youth, and retail policies protect youth from tobacco industry tactics. So these policies change the environment to one that creates a social norm that doesn't support smoking or tobacco use, and it reduces youth access to tobacco products and motivates smokers to quit and supports quitting. These policies also make staying quit easier. Local policies, when implemented in a strategic way, can result in statewide policy change. And so these local policies can also prompt industry change, as we've seen with the recent move by CVS to stop selling tobacco products, because more than 50% of the population in Massachusetts is covered by a local regulation that bans the sale of tobacco products in pharmacies. So we applaud CVS. As an example, cigar packaging, another regulation, it's a youth prevention strategy, and it's also a pricing strategy. Local municipalities have been adopting regulations that prohibit the sale of tobacco use of cheap single cigars. And when single cigars, they may still be sold, but they can't be sold for under $2.50. So in Massachusetts, we're proud that cigarette smoking is declining among our youth. And the 84 Youth will tell you that they got their name because it stands for the 84% of Massachusetts youth who choose not to smoke. But they really are looking to change the name, and we already have the rights to the 90.org. So when the funding cut brought our budget to $2.5 million, the youth smoking rate plateaued. And then as the funding increased, youth programs were restored, and the model regulation was introduced. More regulations were being passed, and more youth were involved. And then there were also tax increases at both the state and federal level. Priority 3, increasing the price of tobacco. One way to increase the price of cigarettes is by raising taxes, and Massachusetts has one of the highest cigarette taxes in the country. We also have a minimum price law that helps us to keep the price of cigarettes reasonably high. The minimum price for a pack of Marlboros in Massachusetts is $9.54. And this formula, it attempts to determine the cost to the retailer of selling cigarettes, and then it protects small businesses from unfair pricing practices of larger retailers. So this is not a public health law, but it certainly has public health benefits. And then as the price of cigarettes goes up, consumption goes down. Priority 4 is to ensure that all smokers receive an intervention by their healthcare provider. The QuitWorks program has been instrumental in establishing a system of referral for healthcare providers. The provider sends the referral to the QuitLine, and the QuitLine counselors contact the smoker. And then the QuitLine sends a report back to the provider. This has increased our calls to the QuitLine. It's increased the number of smokers who receive an intervention by their healthcare provider. And technical assistance is also provided to these healthcare professionals in tobacco treatment interventions and also in the QuitWorks referral process. And so there's been a steady increase of providers who recommend some form of tobacco treatment in Massachusetts. So, protecting all Massachusetts residents from secondhand smoke. Massachusetts has a very strong smoke-free workplace law. And, we have a very strong smoke-free workplace law, and compliance with that law is really very high. So then when the community transformation grants came about, Massachusetts got a community transformation grant, and what we were able to do is move into smoke-free public housing. Because of our strong infrastructure, we were able to really act quickly and reach out to local public housing authorities and residents of those housing authorities to teach them more about the dangers of secondhand smoke and secondhand smoke and smoke-free housing policies. Because of that, and because of that strong infrastructure, our local programs did all of that outreach. They worked with statewide technical assistance providers, and now you can see that the number of smoke-free public housing authorities has dramatically increased over the past 3 years, and the number of smoke-free units of public housing has also increased. The computer just really wants me to get to this slide. Is it timed? I'm sorry. Okay, so we've learned and adapted to changing conditions over the past 2 decades, and we've seen an increased impact with standardized language in our sample regulation and a priority set of policies. We've also seen that youth groups are really valuable in educating stakeholders because they bring real-life examples, and that comprehensive program is just essential. It's critical that we're able to refer smokers to free cessation services when environmental policies motivate them to quit. Some laws and regulations must be adopted on the statewide level, such as taxes or the minimum pricing, but local policy, local public health regulations can really pave the way for state level leadership. And as you can see, local involvement in tobacco control programs in Massachusetts is really important. MTCP works to support the Million Hearts Initiative by creating environments that encourage smokers to quit, supports sustained quit attempts, and reduces exposure to secondhand smoke, thereby reducing the risk for heart disease and stroke. Thank you. And our next speaker is Patricia Cummings.
Hi, good afternoon, everyone. Today I'm going to discuss our efforts to improve cardiovascular health through sodium reduction efforts in Los Angeles County. Although there are numerous Million Hearts related programs in LA County, today I would like to focus our attention on sodium reduction, including some specific and measurable successes we have had, what we have learned, and what we're planning for the future. Just like in too many parts of the country, almost a quarter, or 1 in 4 adults in LA County have been diagnosed with hypertension. This is a key risk factor for heart disease and stroke, which are leading causes of death in the county and the U.S. One solution to lowering your blood pressure is to reduce your sodium intake. However, current levels of sodium in the food supply are high and not safe, and it can be difficult for even the most motivated consumer to reduce their sodium intake. To address this issue, the Los Angeles County Department of Public Health launched a number of field pulse surveys to gauge the opinions on sodium. And the results revealed a majority of adults in LA County believe there should be restrictions and reductions in packaged and restaurant foods. So to address these concerns, the Los Angeles County Department of Public Health launched its Sodium Reduction Initiative in 2010. And this was done through funding from the Centers for Disease Control and Prevention's Sodium Reduction in Communities program. Since the launch, we have worked with County and City of LA government departments, school districts such as the Los Angeles Unified School District, and hospitals to implement strategies to improve food service venues and reduce sodium intake. The Los Angeles County Department of Public Health also simultaneously launched its Healthy Food Procurement Initiative in 2010. Shortly thereafter, our local governing body for the Los Angeles County region passed a motion requiring the Department of Public Health to review and make nutrition recommendations for all new and renewing food service contracts in the county. Since passage of this motion, we have worked with 6 out of our 12 county departments that serve, procure, and or distribute food. And I will be presenting evaluation data shortly about one of these departments, our CEO department, as a case study. But first, our county government structure is comprised of 37 departments with over 100,000 staff. These 37 departments are spread across 88 cities and provide services for over 10 million residents, which is more populous than 42 individual U.S. states. Out of the 37 departments, 12 of them purchase, sell, and or distribute food. And they fall into one of 2 categories. The first is our non-retail or meals served to our dependent community members. And the second is retail or food sold on our government property, such as our cafes or snack shops. From these 12 departments, we serve a conservative estimate of 37 million meals and snacks each year. So to operationalize our healthy nutrition standards, our department utilizes a 5-phase process framework. And the first phase is where we investigate factors that may impede healthy eating by conducting a needs assessment. The second phase is where we identify and educate our key stakeholders that are our champions in this work. And the last 3 phases of adoption, implementation, and evaluation, I will go through in a bit more detail now. So the contracting process, which includes the request for proposal or invitation for bid process, is very similar to like applying for a grant. The prospective vendor needs to provide a letter of intent and then submit a proposal. DPH then, our Department of Public Health, then presents our nutrition standards at the bidders conference to answer any questions about the contract requirements or our nutrition standards. Once the vendor is chosen and executes the contract, our department recommendations in the RFP or request for proposal now become contract requirements. For example, in one of our vending contracts, the recommendations for placement and promotion strategies, such as advertising healthy beverages and placing water at eye level, are now considered contract requirements since the vendor has officially executed this contract. In addition to these contract requirements, if the contract is for vending machines, our governing board also mandates that all county contracted vending machines must adhere to these specific nutrition standards. For example, snacks in our vending can have no more than 360 milligrams of sodium per individual item or package. So to assess adherence of these guidelines, we conducted an in-depth evaluation of our largest vending contract, which covers over 500 plus vending machines across 200 locations in our county. And we collected data before and after implementation. And as you can see, we saw an improvement in adherence in both our snacks and beverages, leading to 122% improvement in adherence for snacks and 35% improvement in adherence for our beverages. For our sodium averages, we analyzed multiple data sources, including sales data, product list information, and environmental scan data using the Validated Nutrition Environment Measures Vending Survey, or NEMS-V. From these data, we were able to identify, on average, a 57% reduction of sodium in packaged snacks before and after implementation of our nutrition guidelines. So the question that we all want the answer to is, what is the impact of our sodium reduction efforts in the county? Well, programmatically, the average sodium per packaged product adheres to our county vending machine policy nutrition standards, which in turn improves the health of our employees, our visitors, and our clients. And to translate this into measurable outcomes, we use the Future Elderly Model, which is an economic demographic microsimulation, and we applied it here to calculate preliminary estimates of a modest reduction among 51 years of age and older population in Los Angeles County. And we examined different scenarios in which salt consumption of this population is hypothetically reduced by 1 gram per day, or in other words, 400 milligrams of sodium per day. And this translates to about 2 lives saved every week and a substantial amount of savings in total medical spending between $2 to $3 billion in Los Angeles County over the cohort period. These 2 lives saved per week is equivalent to about 100 lives saved per year. And this translates to an upwards of 500 lives saved and up to $700 million in medical costs averted in Los Angeles County over the 5-year period covered by Million Hearts. So what are the limitations and lessons learned from this case study evaluation? Well, 1, vendor product list information cannot be assumed to be what is in the machine. As we found from doing in-person environmental scans and comparing it to the product list information provided by the vendor, there could be differences in the two. 2nd, partnership with the department and the vendor is valuable for adherence, and evaluation is absolutely essential. Lastly, in terms of next steps, we will continue to collect sodium intake data and monitor our end results. In closing, I would like to thank my colleagues at LA County for their contributions and ongoing work on this very important issue. And I would like to now bring Janet Wright back up to the podium. Thank you.
Wow. Today's speakers have offered us all powerful examples of the clear signal that small, smart, sustained actions can protect our family, our friends, our coworkers from heart attack and stroke. We ask you today to make prevention of cardiovascular disease a priority for yourself, for your home and your family, for your practice, and for your community. We ask that you measure your way to better health and let us know your progress. And finally, help find those at risk for this preventable disease. Connect them to healthcare and to community resources, and do not rest until that risk is controlled. The clock is ticking, we will be counting, and the nation is counting on you. Thank you. I think we'll be taking questions. We have microphones at both sides. Oh, we've got microphones and runners. And we'll also be taking a few questions, I think, from social media. Please. Please.
This was a phenomenal panel. Thank you very much. It's always good to see how you take the guidelines and then you implement them using your local flair. And I heard collaboration, dissemination. So thank you very much for that. So my comment actually is to Janet, because this is a request. When we try to collaborate, it's really helpful within a state to know who has signed that pledge within a state, so that the people who are within a community can know who we can work together with. So my request to you is a way to make public or available those of us who are working in Million Hearts to be able to collaborate with one another.
Thank you. Good advice. We'll get back to you about that.
Sure. Hi, this is Steve Onifrak in Nutrition, Physical Activity, and Obesity here at CDC. I had a question for Patricia regarding sales for the vending. Could you maybe comment on trends in sales that you maybe observed? And
There's 2 Patricias, so I'm laughing. We are in the process of examining sales data in terms of revenue. Currently, we have used it, it was on the slide, we've used it to weight our data because, as you know, you can calculate averages of sodium, from your product list information and nutrition analysis data, but you can always also use sales data to weight it to actually get at a more accurate picture of, well, what we use as a proxy for consumption. It's not really consumption, but we're getting at more of what people are purchasing and seeing if what they're purchasing is higher sodium than what's available. So we are in the process, however, of moving this analysis forward. These are the newest results, so all of you are hearing firsthand. This data has just been released, so we are in the process of continuing that to look at revenue.
From our online and social media audiences, is there research on the relationship between heart health and remaining connected to family and in community? To anyone?
There is. I'm not an expert in that area, but we know that the connections that we have contribute to our mental and physical health. I couldn't quote you a source for that.
Not sure if this is what they're getting at, but certainly we know that from some studies around FIT, which is something we've done locally called Families in Training, where we have families that stay healthy together and work together. It's another program that I believe is offered through our YMCA right now, where we'll have families sort of working together, working out together, getting dietary and nutrition information together, so that it really feels like a more collective approach to how a family feels better. I think certainly there's research out there that could probably support that.
My question is to Dr. Tremblay. You were able to develop a protocol for managing the improvement of the medications. Were you able to incorporate some of the discount medications, those $4 formulas that are more accessible to all?
Absolutely. Yeah, I think that's one of those things that really depends on your community, because each community has different stores and different pharmacies that have these deals. For us as providers, at least in our organization, there's very few times that we're ever using any brand name. I hate to say that, but it's true, because almost everything is $4 or $9 for 3 months supply, and we're very sensitive to that issue with our patients in general. And so as part of medication lists that we provide as part of our EMR online tool are the lists of all of the local pharmacies that do offer those plans. So if there's ever any question for a provider, that information is available. Most of the studies that are out there, such as the All Hat trial and a few others, also usually are focused primarily on generic type medications. And as a result of that, that's the evidence that we use to support our algorithms. And so we build those into our practice. Mm-hmm.
Another question from our online audiences. Are there data or breakdowns on which ethnic groups are most affected by heart disease? And do we have a resource for that information?
We actually have some information on our website about that. That's Million Hearts, as well as the CDC has data that they could offer. I have a question, and I think this might be for Patricia Henley and maybe Andrew. Patricia, I'll start with you. In Massachusetts, you mentioned the QuitWorks, which, as I understand it, helps providers do a good job of offering the interventions. Could you speak to the obstacles that providers mention when what problems is QuitWorks helping them solve?
Well, QuitWorks has really helped them solve the issue of what to do when they find somebody, when they work with somebody who smokes. They have felt in the past that there were limited resources and limited places to actually train the providers in just doing that, giving them a source of help, because of free quit. But the idea that then they would refer and then the quitline staff would call the smoker, it was in the patient card, and you go ahead and call this number and then I'll call. So it made that connection and made it just a lot more helpful for the provider and for the smoker. And then for the provider to actually find out what happened after that. So the quitline staff reach out to the smoker and then provide a report back to the healthcare provider so that they knew that that connection was made, it was not made, and that question needed to come again at the next visit. And I think that just gave more tools to the healthcare provider. That's right.
Similarly, I think one of the big things we saw is that you, if you may recall, the list of barriers was that one of the classic examples that was brought up was I would see a patient in my office in January who had high blood pressure. At the time that I saw them, their blood pressure was fantastic. There was no need to really do anything different. And then suddenly, somewhere in the system, 4 months later, they would show up for acute care somewhere, injury or a cold or something, and their blood pressure is elevated. And suddenly there was no connection back to primary care, and that was one of the barriers that we encountered. And so providing tools that didn't just sit alone in the provider's lab about trying to monitor all of these things on their own was a critical part of getting the engagement of the primary care providers. So that's why we created this centralized process, so that if someone was in orthopedics and had an elevated blood pressure, our expectation was not that the orthopedist themselves would manage blood pressure, but that the staff would be a great way to get them back into the primary care provider's circle of care so that we could address the issue, even if it just meant, hey, stop by next week for a recheck and we'll let you know. And if you need some education, we'll offer that at the same time. So that was a big barrier. And I think the other piece is also just the guidelines, constantly discussing guidelines. What guidelines are we going to follow, what guidelines are we not? And we made it very clear that this was not an attempt to manipulate the numbers or play the numbers game. It really is about delivering healthcare, which is why the goal is not 100%, it's 81% or 80%, depending on your institution. There will always be medical reasons why it's appropriate to let someone's blood pressure be higher than 140/90. We need to respect that as a community and as providers and thinkers, and continually work to improve that.
Do we have any final questions from online or social media?
We do. What can college campuses do among its students and employees to help in this effort?
College campuses can go smoke-free or tobacco-free, and many college campuses are. There are a lot of resources out there. Americans for Non-Smokers' Rights has a website that keeps track of all the different college campuses that are creating those smoke-free policies. And it's not just putting a sign up saying that you can't smoke, but working with the students and the employees of the college campuses, making sure they have resources to help them quit smoking if they do smoke, getting the information out there. But it's a movement that's gaining an awful lot of a momentum. So.
Thank you very much. I'd just like to take the moderator's prerogative, one, to thank our colleagues at Chambly for all the work putting on our session today. I'd like to have a hand for those folks. And a final hand for our speakers, not just for their talks, but for the work that they do and will continue to do every day. And I'd just like to finally note that you heard some good news today. Remember that. Thank you all. Please join us again next month for Public Health Grand Rounds.